Dear colleagues, this is a case of coloboma iris with coloboma choroid with almost mature cataract. I have taken up this case for surgery. The eyelid margin has been covered nicely with plastic drips. Now this is betadine 5% lotion. It has been applied over the ocular surface and a thorough irrigation of the ocular surface is done using ring-lactate or balanced salt solution. And now we can see that the coloboma in this case is looking like a defect in the periphery of the iris. It's looking like iridodialysis with a breeze at the center. So it's a unique kind of coloboma iris. I have taken off this case and I've started. This is the main incision, 2.8 millimeter. Main incision is being placed at 10:30 o'clock. The antechamber is very shallow in this case, and the size of the cornea is a little less than usual. This is a side put incision at around 7 o'clock. I want to stain the anterior capsule of the cataractous lens. An air bubble has been injected into the antechamber. Now this is 0.6% trypan blue dye. The dye is washed out. And now in this case, this is viscoelastic substance. HPMC has been injected into the anterior chamber. This is on more side port at 1:30 o'clock. Now capsulorhexis is to be done. I fix the eyeball with the fixation forceps, introduce the cystitome through the 7 o'clock side port, incise the anterior capsule, and now see as I incise I can make out that the zonule is weak. The whole lens tends to move as I incise the capsule and try to do capsulorhexis. So I now have raised a flap and I'm going to use this Utrata forceps and gently pulling this capsule and making a rhexis. This has been a fairly round rhexis. Now Hydra dissection is to be done. As I inject some fluid just underneath the anterior capsular rim, see what happens. The inferior pole tends to come out of the capsular bag. Now I want to make the nucleus free from the capsule. So I rotate the nucleus for quite some time in this case. And now I inject viscoelastic substance again. Now I want to check whether I need to apply, I need to put a capsular tension ring or not in this case. So what I am planning is I use a Simcoe cannula and see if there is capsular dehiscence inferiorly. I try to pull this cortical matter and I can make out that there is dehiscence, zonular dehiscence at the site of coloboma, and it is almost 2 clock hours. So I have decided to put a capsular tension ring and I'm trying to aspirate some cortical matter so that it becomes easy to put the ring. This is viscoelastic substance again. Now in this case I am taking a viscoat also. I'll apply the viscoat just over the area of zonular dehiscence to support the vitreous humor so that it doesn't peep into the anterior chamber. This is the capsular tension ring. It is thoroughly irrigated, and now I am going to introduce this capsular tension ring through the main incision. The capsular tension ring goes in. The antechamber is very shallow and I am finding it little difficult to introduce the C-tier. At the first attempt it didn't go. So what I am doing is the second toothed forceps in my hand, I'm holding it near that, and now I have got the edge of the anterior capsular rim, and now it is going into the capsular bag and it is supporting the equator of the capsular bag. Now what I'm planning is I'll take a Sinskey hook and I will use the eyelet. I'll use the eyelet at the trailing end of the C-tier like this, and I'll gently take it into the equator, and when I'm sure that it has gone underneath the anterior capsular rim, then only I will release the C-tier from the Sinskey hook. So the C-tier has been nicely placed in the capsular bag, and now I'm going to start phacoemulsification for this case. The case and the machine I am going to use in this case is Oatley Catarix 3 phaco machine. It has got a nice pneumatic cutter system, vitrectomy cutter system. It offers 1200 cuts per minute. It has inbuilt air compressor and the cutter cuts very well. And I have taken viscoat this is viscoat. I am placing over the 6 o'clock angle, and it is I'm pressing the capsule, and my idea is to support this area, and I will do the phaco, and my plan is not to take the phaco tip near 6 o'clock. I'll place the phaco tip towards 3 o'clock, and I will rotate the nucleus and complete phacoemulsification. Since it is very shallow anterior chamber, I enter into the AC with bevel down, and now I turn the handpiece, make it bevel up. I'm in phaco 2 mode. The phaco power is 60%, flow rate is 40, vacuum is 400. I embed the tip, and this is vertical chop of the nucleus. Now I rotate the nucleus and chop it at this place, and this triangular flap is, I'm not going near the 6 o'clock. I'm keeping the tip at 3 o'clock or at the center, just above the center. That's it. The nucleus is coming out nicely. This is not very hard nucleus, that is good for me. The nucleus has not imposed another challenge on me. There is enough challenge in this case: shallow anterior chamber, weak zonular dehiscence at 6 o'clock from 5 o'clock to 7 o'clock. That's it. The viscoat has nicely supported the 6 o'clock area. Now before I come out, I want to inject viscoelastic substance. I hold the cannula hub and I ask my assistant to inject HPMC, and then I come out. Now in this case, as I try in other cases, I tried to remove the cortical matter with 23 gauge Simcoe cannula, but I could not remove the cortical matter with this 23 gauge Simcoe cannula. I could not pull it with enough strength with this Simcoe cannula. So I have asked for bimanual IA, and my assistant is making it ready. So here it is, the irrigation aspiration of Oatley system. Little bit of viscoelastic substance has been injected into the anterior chamber to protect the corneal endothelium, and now this is the bimanual IA. The irrigation is entering into the AC through the 7 o'clock side port, and now I am trying to remove the cortical matter from 9 o'clock. The CTR resists the pull of the aspiration probe. However, there is enough strength of the aspiration, and I become successful in removing the cortical lens matter. This is the cortical matter from 5 o'clock. Now I want to change hands. The irrigation is now going through the 1:30 o'clock side port, aspiration through the 7 o'clock side port, and I am removing the cortical matter from 1 o'clock and from 12 o'clock. Yeah, it is coming now nicely. This is the 12 o'clock cortical matter. It is coming very nicely. This is the cortical matter at 3 o'clock, and I could remove it very nicely with the aspiration probe. Now some cortical matter is remaining there at 6 o'clock. I support the capsular bag with viscoelastic substance, and then I come out. And now I again go into the antechamber. The irrigation is now through the 7 o'clock side port, and the aspiration is through the 1:30 o'clock side port. I checked the intraocular pressure. It is on the higher side. There is some vitreous upthrust. There is some vitreous upthrust. However, hopefully I will be able to complete the case. Now this is the cortical matter. At here we could see the CTR. As I pulled the cortical matter, the CTR was visible, and we can see the CTR at the coloboma iris, which looks like iridodialysis. You can see a white line, that is the CTR. Now cortical cleanup has been done nicely. Antechamber is very shallow. There is some vitreous upthrust. However, I will be able to put this lens. This is a hydrophilic acrylic intraocular lens. It is called Flexion. This lens is very flexible, more flexible than Appasamis Acrifold or Spectrafold, and in this case this lens will help me in placing it in the capsular bag, since it is a very flexible intraocular lens. The leading haptic has gone into the capsular bag. Now I am trying to place the trailing haptic to place into the capsular bag with the chopper. And here it is. It goes into the capsular bag with some strokes. That's it. I have been able to place the intraocular lens in the capsular bag. Now this is removal of viscoelastic substance. I am using a Simcoe cannula to flush the viscoelastic substance and to aspirate the viscoelastic substance. Now there was some cortical strand which came off, but one cortical strand is still there at 6 o'clock. I formed the antechamber with Simcoe cannula and I came out. Now I want to take help of bimanual IA and remove some more viscoelastic substance. This is the irrigation only. Since the antechamber is very shallow, I could not go behind the IOL, so I'm taking some longer time. Here it is. The cortical matter at 6 o'clock has come off. I'm taking longer time from the anterior surface, remaining on the anterior surface of the lens to clean most of the viscoelastic substance. I followed up this case. I did the surgery at around 10 o'clock. I followed up the case at around 4 o'clock, and the patient was doing very well. Intraocular pressure was normal, antechamber was okay, normal depth. I've injected some air, and underneath this air I'm injecting moxifloxacin, and now I'm hydrating the side ports to make these wounds waterproof. Since my side ports are a little larger and it is never stressed by the instruments that go through these side ports, there is no fish mouthing of these wounds, and they remain waterproof in the postoperative period very well. The final wash, and this is formation of anterior chamber. Now I check whether there is any leakage from the wounds. I can see that all the wounds are waterproof. I feel the anterior intraocular pressure digitally. I feel that it is normal, and that's it. So in this case, I have overcome several challenges. Number one, very shallow anterior chamber, zonular weakness and dehiscence of zonule for 2 clock hours, vitreous upthrust, and that's it. This is a happy ending. Hope this video will help you in developing your surgical skills, and I believe that you can do better surgery than what I can. Thank you very much for your patience, for watching so long. Thank you once again.